فيرست سبيكر دكتور أحمد سعيد الملاح، وهو تلميذي النجيب وعامل معايا الماجستير وعامل معايا الدكتوراه، وراجل أنا أشهد له بالخلق والعلم إن شاء الله. He will tell us about outcome of endovascular-first approach for the treatment of TASC 2 Class D Femoro popliteal occlusive arterial disease. اتفضل يا دكتور.
شكرا جدا دكتور حاتم. أنا والله سعيد جدا النهارده إن بادئين أساتذتنا وزمايلي. فرصة سعيدة جدا. أنا بس دقيقة واحدة اللي أعمل لود للبرزنتيشن.
لا ده بتاعنا بس.
نعم؟ لا أحمد اللي هو الأوتكم أوف. لا مش ده سيشن كام؟ سيشن 4 ولا 4؟ 2 بقى 2. طيب شكرا.
عشان عماله بزيتك
في مشكلة في المساحة. بتاع مش سكوب كده. بطلع في دقيقة كويس شوية يبقى كويس. ايه المشكلة؟ أنا مش يعني واخد من هنا.
عايزين نرجع الشاشة. ماشي خلاص ماشي. انا قلت بس ممكن اعملها من عندنا.
نكس من هنا. تمام كده احسن. شكرا. Outcomes of endovascular-first approach for treatment of transatlantic intersociety consensus Class C and D femoral occlusion arterial disease. This research was done in St. James's Hospital. This is the largest teaching hospital in Republic of Ireland. It has about more than 1,000 beds and has a special vascular unit, St. James's Vascular Institute. Endovascular treatment and open vascular surgery, bypass surgery, are two known modalities for treatment of lower limb peripheral vascular disease. There has been multiple studies studying both, and one of the most famous trials is the Basel I trial, and they concluded that there was no difference in critical limb ischemia between endovascular and surgery first option. However, it is well known that not all patients will benefit from endovascular treatment, especially even if they respond in the beginning. There is always a problem with the durability of the bypass surgery, of the endovascular treatment. And bypass surgery is associated with other problems of increasing morbidity and mortality. At St. James's Vascular Institute, the strategy that was adopted was endovascular-first for management of patients with peripheral vascular disease who would require revascularization. Sorry. Just before I start the presentation, I would like to explain what is TASC 1 and TASC 2, TASC 2 for non-vascular colleagues. TASC is a consensus, transatlantic intersociety consensus that was first done in year 2000, and it is consensus between 14 vascular societies, vascular radiology and cardiology, and that was the second version was in 2007, and they concluded that surgical bypass is preferable in TASC C, and the surgical bypass is recommended as a treatment modality for TASC D. This is the TASC classification. TASC C, we're talking about increase in the vascular disease from TASC A to TASC D, and TASC C include patients with multiple stenosis or occlusion totaling more than 15 centimeters, or recurrent lesions that needed treatment after two endovascular treatment. And TASC D is full total occlusion of either common femoral, superficial femoral artery, or popliteal or proximal tibial disease. So the aim of the work was to evaluate the technical success, morbidity and mortality, and long-term results of TASC C and T femoropopliteal lesions treated by endovascular procedures. We looked at patency rate, amputation-free survival, re-intervention-free survival. We were particularly interested to analyze the influence of patient, procedure, and lesion-related characteristics on those outcomes. At St. James's Hospital, we have a database called VascuBase. All patients are that had procedure, the data are entered in such database, and it's managed by an independent data manager. So we put the data manager will manage it and make sure that any follow-up data is added prospectively to that database. We did a search and identified all patients who had infrainguinal angioplasty between year 2000 and 2015. And we looked for patients who were diagnosed as TASC C and TASC D lesions and were selected for further analysis. And we did a Cox regression analysis, was performed to realize factors that are predictable of outcome. We recorded or found 1,713 patients for infrainguinal disease, out of which there was 720 procedures were done for patients with TASC C and D on 578 limbs in 502 patients. Male to female was about 322, and this mean age 72 plus minus 10.8. Just few definitions. We defined procedure success as established of inline flow without any residual stenosis of more than 50% or any suboptimal results on the completion angiogram. Primary patency, patients which remained patent without any revascularization in the follow-up period. And secondary patency that treated vessels required further intervention to open it when become diseased or occluded. And we looked at each angiogram of the 720 patients to record the run of vessels. So we used a classification for run of vessels that was developed by Rutherford back in 1993. This was depending on the how good is the runoff, which is very important in vascular surgery. So any patient with tibial vessel that has less than 50% disease, even one single vessel of the 3 tibial vessels, is classified as 2, giving 2. At least one vessel with more than disease, but more than 50% is giving 1, and no runoff vessel is giving 0, which is poor runoff. We treated all patients according to the Rotel protocol. We used dual antiplatelets for 6 weeks after surgery, aspirin and clopidogrel, and we continue aspirin indefinitely afterwards as an antiplatelet. Patients were attending follow-up at 6 weeks, 3 months, and 6 months, and every time they have a clinical assessment in outpatients, duplex ultrasound of the treated segment, ankle brachial index, and toe pressure index. So our follow-up, median follow-up was 20.3 months. This table represents patient demography. You can see the comorbidities are like what we do expect with vascular patients, quite poor, smoking, renal disease, diabetes, ischemic heart disease. The indication of intervention was diverse, as you would expect for vascular patients attending any vascular unit. So this is a real-life study. Urgency were mainly emergency or urgent, but we still recorded about 50% or 75%, 57% as elective procedures, but that require treatment electively. Stent was not something that we were doing frequently in such study. This study was done over 16 years period, so we only used femoral-popliteal stents in femoral-popliteal segment only for about 2 years, and the policy of the department was not to use the stents. There has been loads of talks about the stents these days, especially drug-coating stents. Treated lesions ranging from occlusions, 64.3%, stenosis 27.9%. We the distal runoff, as we had to review each single angiogram, and you can see runoff ranges from poor, moderate, or good, depending on the scores that I discussed, 1, 2, or 3. We have missing data from, because all the angiograms are on the computer system. Before year 2005, all angiograms were still on the cards, on the X-ray films. So these are, we couldn't collect data about many of those patients, and we only depend on the recorded data in the system. So there's nothing, it is missing data, and account for about 23% for distal runoff vessels. TASC C and D 64.3 and 50 and 35.7. Overall complication rate was about 10.2%, about 74 patients, ranging between local complications and systematic complications. You can see the different local and systematic complications. Immediate technical success was recorded in 635 patients, that's 88.2%. And in the other 85 patients, there was an immediately failed angioplasty. The outcome of the failed patient was actually done in a separate research, but this is what was the fate of such patients. 53 patients, 51% underwent successful bypass, 8 of which subsequently had amputation due to occlusion of such bypass, and 26 patients had primary amputation, major amputation. This figure represents overall patency rate, which really represents the secondary patency rate. So after 5 years, the patency rate was, the secondary patency rate was 68.9%, which is a good number compared to even to bypass surgery. That usually the FEMPOP segment for bypass surgery 5 years patency is about 65%. But those patients, you can argue that as well, the about 42% required further intervention. This is the re-intervention free survival, recording the number from year 1, year 2 to year 5. You can see the actual primary patency rate was 58.4% after 5 years. So 58 of the patients got away with only one intervention, endovascular intervention in the beginning. Amputation-free survival were surprising for us. Like patients after the first year were free from amputation, 88.8%, and the diagram remained plateau at the whole 5 years and reaching about 82% after 5 years. And the overall survival was declining steadily over 5 years. This would be expected with all patients with such advanced cardiovascular disease, and only 68% were alive after 5 years. This is I think the most important slide of the presentation, representing the multivariate analysis. So as you see, those patients has plenty of diabetes, renal disease, and cardiovascular disease, cardiac disease, and renal disease. And all of this we did in smoking, and all of this we did in Cox regression to analyze which factor would affect the reocclusion, amputation, and mortality. So we found that angioplasty for tissue loss as an indication for intervention, smoking, and distal runoff was a predictor factor for reocclusion of the angioplasty. We found that intervention for tissue loss, poor distal runoff, renal disease, and urgency of the procedure were identified as predictors of amputation, major amputation. And similarly, old age, renal disease, and urgency of the procedure were predictors of mortality for such patients. We didn't find that TASC and TASC D per day were not statistically significant to predict any of the above studied factors. So our study has some limitation. It was done in a single center. It's a retrospective study. However, the fact that it's happening on a prospectively maintained database gives it strength. There is an absence of control group, so this would be an ideal to be done with a bypass group. However, we have a large number of patients, 720 patients, and to our knowledge, this is the largest study that was done on TASC C and D patients in 2016 when we finished the study. And something that may be considered as positive or negative points, that there was heterogeneous patient population and many confounding factors. However, this heterogeneous patient population from many indication represents really the daily life and vascular surgery unit, so it will add the external validity of the study. And it was important, we did study the confounding factors in the Cox regression analysis. So there are plenty of positive points, as the minimum loss of data, large number of patients, and different indications were added to the study. So in conclusion, Endovascular-first strategy is an acceptable managing strategy for patients with TASC C and D Femoro popliteal lesion. Endovascular-first approach is with an acceptable outcome, comparable, if not even, than some published bypass surgery outcomes. And factors predicting angioplasty success identified in the study are similar to those that will be required as well for a successful bypass, with however with a lower mortality and morbidity compared to bypass surgery. Thank you very much.